Hello, my name is Dr. Jay Lerner,
And I'm Dr. Gerard Lemongello.
and we'd like to thank Dental XP for giving us the opportunity to present today's webinar entitled Predictable Implant Aesthetics, a Prosthetic Technique. Dr. Lemongello and I have been in practice together for the past 15 years. We practice in an area called Palm Beach Gardens here in South Florida, where we're actually having some beautiful weather. So if you're in another part of the country or another part of the world where you're having some cold weather, please come visit us. We'd like to start today's webinar with a quote from the book Alice in Wonderland. As Alice is on her journey, she meets the Cheshire Cat at a fork in the road, and with no clear-cut destination, the following conversation transpires. "Cheshire Puss, would you tell me please which way I ought to go from here?" "That depends a good deal on where you want to get to," said the cat. "I don't much care," said Alice. "Then it doesn't matter which way you go," said the cat. So let's take this to your practice now. You have a pretty young lady who gets referred to you by your local oral surgeon who saw her in the emergency room because she fell and she had trauma to the front of her mouth. Her front two teeth were knocked out and they were splinted in place by the oral surgeon. And as you can see, she suffered fractures that really went subgingival and down to the level of the bone. And basically, these are hopeless teeth. So when this pretty young lady comes to see you and she's knocked out her front teeth, which is showing to the whole world right in the front of her mouth, you better care which way you're going to go. You better have a plan. And if we're going to replace these teeth with implants or any type of bridge, it better look good because the whole world is seeing this being in the front of her mouth. So about 25 years ago, cosmetic dentistry came to the forefront and everybody was a cosmetic dentist. Now with the popularity of implants and all the new technology and how we can make implants look natural, everybody's an implant dentist. Well, I don't want you to think of yourself as a cosmetic or an implant dentist, but I want you to think of yourself as a comprehensive dentist. And what is that? That's a dentist that has knowledge of restorative care, aesthetic care, occlusion and function, implant dentistry, and the relationship that all of this has to periodontal health.
For those of you who have been practicing for a while, we understand that implant dentistry has been a journey. In the beginning, the outlook was a little foggy. We didn't quite know what the predictability would be, where the implant success would go. But as time went on, we found that what we thought was success was just getting osseointegration of a posterior fixture and the placement of a crown. But as time went on and the journey continued, we realized that now we had components and the predictability to create lifelike aesthetic results, both in form and function, in the posterior teether. But the beauty of that was that now we could take the things that we learned in the posterior and go ahead and apply them to the anterior segments. So that if we have a person who has a deciduous cuspid and is in need of a replacement of that tooth, we can take the things that we learned in the posterior and apply them in the anterior and have beautiful lifelike results. Implants have revolutionized how we treat missing teeth today. Dental implants have excellent success rates, and there are many advantages over fixed or removable alternatives. Long gone are the days where we had to prepare down healthy natural teeth in order to replace a missing tooth, or use complicated engineering to create some form of removable appliance that was large and unaesthetic and cumbersome and difficult to wear. Today we routinely use dental implants with predictable lifelike results, often challenging the ability to tell which is the implant and which is the natural tooth. Implant restorations do, however, present some challenges, depending on the type of osseous defect that we're presented with. We can go ahead and classify these osseous defects into three different types. Type 1 is the more ideal osseous site, situation with the deciduous cuspid, where the loss of that tooth is still going to result in considerable bone and a very successful result. In type 2 cases, a little different, a little bit more complicated. Here we have a vertical defect where both the labial and palatal bone is missing, but fortunately we're able to preserve the interproximal bone, which will help us for predictability and restoration. And then we have the type 3 site, which is the most difficult to restore. It is not only a vertical defect, but it's also a horizontal defect where we've lost labial and palatal bone as well as interproximal bone. This becomes a much more challenging situation. So preserving the gingival soft tissue architecture can be difficult in the type 2 and the type 3 defects. The osseous tissue has to be and is the framework for the development of the healthy aesthetic soft tissue. Preservation of the interproximal bone level on adjacent teeth is essential because it's the interproximal bone that's going to support our soft tissue and help to support the interdental papilla. So in a case like this, where we know we have imminent loss of the two lateral incisors due to large posts or large posts and cores, and these teeth are mobile and in need of replacement, we know that we can use techniques today that as long as we preserve the interproximal bone, we can preserve the interproximal papilla and have successful lifelike results. Here's another case, another example, where we have the imminent loss of the central incisor and the lateral incisor. And again, with the loss of these teeth, utilizing predictable restorations that we have available to us now in abutments, we're able to preserve the interproximal bone, which allows us to preserve interproximal tissue and have aesthetic, lifelike results. But we have to understand that the importance of the implant design takes a part in this, because the preservation of the interproximal bone level on adjacent teeth and the supporting interdental papilla is based on how the new implant systems are designed. If we remember in the beginning, first we came up with something called platform switching, which was the newest change in the platform of our implants. And by platform switching, what it did is it allowed us to change the position of the microgap and internalize it onto the head of the implant so that we could keep the bacteria that accumulated there away from the bone level due to the horizontal offset. And in today's world, we have implant systems that have built these platform switches into the heads of implant, which makes restoration much more predictable. One of the key points that we need to consider, however, is the classic study that was given to us by Dr. Tarnow in predicting the papilla growth between adjacent teeth. What we've learned from his classic study is not only would the 5 millimeter rule is valid between adjacent teeth, it's also valid for interproximal bone adjacent to implant teeth. That 5 millimeter rule states that when measuring from the contact point of the restoration to the crest of the bone, the papilla will fill the space if the measurement is 5 millimeters or less 100% of the time. The important thing to realize here, though, is that even with the loss of 1 additional millimeter of bone, that we're going to have only a 50-50 chance of closing that interproximal papilla space. In another study that went ahead and confirmed the predictability of the implant between adjacent teeth, it took the study a little further and gave us information regards to implants and implants to pontics and pontic designs. In this study, and in a situation where we have considerable bone loss in a type 3 case, what we find is that we may be more predictable in using a fixed bridge in a case like this, with a bone graft and possible extrusion, and a fixed bridge where we're using 2 pontics, because we've learned from this study that we have more freedom. We have 6 millimeters from the contact point to the bone level in order to get closure and a papillary growth. Another study that's important and a key point is the effect of the interproximal distance on the height of the interproximal bone crest when implants are placed next to each other. In this study, what we see is when implants are placed next to each other, we need to adhere to what we call the 3 millimeter rule. Those implants need to be placed at a distance greater than 3 millimeters so bone loss does not occur or overlap in between. So in this case, if we have the implants too close, the bone loss occurs in between the implants and we have a loss of interproximal papilla.
This is a case that came into our office and presented with the chief complaint that he was not happy with the aesthetics of his anterior bridge. As you can see, the patient lost the upper left central and the upper left lateral, and there was a lot of bone loss, both horizontally and from the facial aspect. As we look from the side, you can see the concavity that was on the facial aspect of where these teeth were extracted. One of the good points of this case, and one of the saving graces, was that we were going to be able to do crown lengthening due to the short clinical crowns on the right side, on the upper right central, lateral, and cuspid area. Here's the patient's x-rays from 2000 before he had this traumatic accident, which resulted in the loss of the upper left central and the upper left lateral. But when you look at the x-rays from 2004 that the bridge was done by the previous dentist, you can see all the bone loss where these teeth were extracted, and there wasn't any procedures done to replace the bone or any bone grafting procedures done that would be able to give us either a bridge or placing implants here that would at least make the area look more natural. Once the bridge was removed, we could see the loss of bone that we had both in the horizontal and vertical dimension, and also the concavity we had on the facial aspect of the ridge. This case was referred to our periodontist, Dr. Robert Holt, in West Palm Beach, Florida, and Bob flapped the area back to see what he was dealing with, and we could see the defect. He then went ahead and harvested 2 cores of cortical bone from the chin and fixated it to this concavity on the facial aspect, and then filled in the rest with cancellous bone. This was allowed to heal for about 6 months, and upon re-entry you could see all the nice bone that is filled in. We went ahead and placed 2 implants in this area next to each other. When it came time to restore this area, we restored it with 2 zirconia abutments. There were teeth that were also missing in the areas of the upper left first and second bicuspid, and those were restored with titanium abutments. Here's the patient's pre-op retracted view, where we had the huge concavity in the pink porcelain to try to mask the defect. And here we ended up doing all single unit Emax crowns over the 2 zirconia abutments on the upper left central incisor and the upper left lateral. Here's a radiograph of the 2 implants next to each other, and you can see where the implant is next to the natural tooth, we were able to keep the peak of bone. And in the bone grafting area, because the implants were separated by at least 3 millimeters, we were able to keep that bone. But when we're dealing with implants next to implants, we're not going to be able to have that papillary growth that we had between the implant and the natural tooth. So how do we deal with this? Well, one of the ways we're going to deal with this is with our restorative dentistry. We're going to fabricate our porcelain restorations in such a way that we're going to bring in the mesial line angle. So that's going to decrease the facial plane on the lateral. And then what we're going to do is go in and shade the interproximal area on the distal of the upper left central and the mesial of the lateral, so that the eye is not drawn to this area. Looking at the radiographs again, you can see how we're able to keep the bone between the implant and the natural tooth, and this is due to the platform switching of the design of the implant. As you can see, here's the pre-op smile and the after smile, and with the 2 implants next to each other, we were able to get around this situation by bringing the line angle in towards the center of the tooth, creating the illusion that this isn't a wide tooth. Another way that we could have restored this case was with a single implant in the area of the central incisor cantling off the lateral, or in the lateral incisor cantling off the central, to try to maintain this papilla. But I feel that we were able to get a really nice aesthetic result, and we chose to go with the 2 implants next to each other. There's the patient's before smile and the after smile. This case was published by myself and Dr. Holt in Implant's Reality. So if anybody is interested in reading this article, here is the reference to that.
So let's go ahead and take a little closer look at the case that Dr. Lerner introduced a little earlier. I want to give you a little history on this young lady. This young lady was 22 years old. She's an actress and a model. So this was a very traumatic injury for her. I want to also describe what she'd presented with was these two central incisors during the trauma had been pushed back at nearly a 90-degree angle with the loss of her left central incisor, about the 2/3 of it as it presents. When we saw her, we knew that these were most likely hopeless teeth. She had been seen by the oral surgeon who needed to stabilize the situation so that we could assess it at this time. So taking a closer look at the x-rays, what's deceiving here is how deep the fracture lines are below the palatal aspect and the palatal bone. So let's take a few minutes and start to think about how we might treatment plan a case like this. How would you treat this case? Well, here are 4 of the options that we could consider. The first would be endodontic therapy, extrusion of the remaining portions of the teeth, crown lengthening, and then eventually a post-incorporate crown. Second possibility would be the extraction, bone graft, and immediate implant placement of either 1 implant for aponic or 2 implants for both teeth. Third option would be extraction and bone graft and then delayed implant placement with 1 or 2 implants, as we discussed before. And the third possibility would be a fixed bridge, tooth retained with ovate pontics. What are the advantages and disadvantages of each of these treatments? Well, if we consider endodontic therapy, extrusion, and crown lengthening, the situation here is we have to understand we have a 21-year-old, 22-year-old young lady. And we need to think about what the predictability of restoring these teeth would be with endodontics and extrusion and what that might look like both in tissue and integrity as she began to age. We also need to consider the second option. If we extract and do bone graft, what are the chances of us removing these teeth, having good bone graft and immediate placement of implant, and being able to preserve bone and tissue at the same time? We need to consider what the advantages and disadvantages would be of extraction, bone graft, and delayed implant. At least this way we'd be able to maintain bone and preserve bone and have ideal placement of the 2 implants in the future. The only difficulty here would be the time that it would take, meaning that it would be a large commitment over time to restore in this option. And then the last option would be providing with a fixed bridge. The disadvantages here, though, as we know, is that we would need to prepare healthy teeth in order to support the missing central incisors. How would we consider to provisionalize the case if we decided to do these different options? Well, with an extraction and bone graft and immediate placement, we could go ahead and place a temporary bridge from lateral to lateral. We could use immediate implant-supported temporary restorations, or we can use a removable provisional flipper of some form. With extraction, bone graft, and delayed placement, same thing. We could provide a fixed bridge or some form of removable provisional because the implants would be delayed in their progression and in their placement. And then the final would be fixed bridge. We would just go ahead and provisionalize with a temporary bridge. But what are the advantages and disadvantages of these techniques? If we consider extraction, bone graft, and immediate placement, how difficult would it be to remove these teeth and immediately provisionalize and get stability again of bone and tissue? With delayed extraction and implant placement, you have the advantages of bone grafting and creating an ideal foundation and structures for soft tissue. But we'd have the time that we talked about before that it would take. And then finally, the fixed bridge. We'd have we'd have pretty aesthetics, but we'd have the difficulty of dealing with the fact that we've tried to remove and prepare these other teeth to hold the bridge. So let's take a minute to treatment plan this case the way we did progress through it. Now, part of what I didn't get to tell you yet is this young lady refused any orthodontic treatment, so extrusion and future surgeries were out. The other is that she needed to be able to continue to work and act. So the idea of a flipper or removable partial was unacceptable as well. Then the third option was creating a fixed bridge, even as a provisional long term, but at such a young age, her and her parents that we consulted with did not want to have any other tooth structure prepared or removed in order to create a better situation. So what we decided to do was to go ahead and use the 2 remaining teeth and perform endodontic therapy on both so that we could assess the integrity of both teeth. And we could then use or choose which one of these would have the greatest longevity in the mouth so that we could go ahead and treat this case in a delayed bone graft and implant placement scenario to try to create the most predictable long-term outcome. So the patient presents this way after the endodontic treatment and the initial composite provisionals in place. We can go ahead and remove the fixation at this point in time, make sure that everything is stable to move forward. She can then present and we can transition from her provisional to implants by preparing the left central and allowing it to hold the 2 temporaries in place while the bone graft and implants are placed, and osseogradation and healing can begin. From there, the provisional goes back on, healing continues. We go ahead and at this point uncover and place our provisional abutment, and we can replace our provisional back in place. And as we continue to transition, we can then use the new implant abutment to go ahead and remove the left maxillary incisor, go ahead and do our bone graft and our delayed implant placement while the provisional is held in by the right tooth. We can continue as the healing occurs and then transition to a implant provisional retained provisional. She can continue to wear this as the healing occurs until we're able to actually go ahead and take a final impression. Zirconia abutments. Whole time preserving as much bone and tissue as we can along the way, adhering to the 5mm and 3mm rule for implant placement. We can go ahead and have a smile that goes from this, from trauma to this, and with an outcome that you see here. And we have to go ahead and quote our friend Dr. Tarnow, accomplish one miracle at a time. So how do we move forward? Well, to ensure the most predictable outcome, the following must be properly orchestrated and completed. We must begin with a proper treatment plan and understand what's best for this patient. We also need to use surgical techniques that are going to reduce the loss of hard and soft tissue. We need to be able to use the placement of healing caps or custom fabricating healing abutments to prevent tissue pressure and collapse. We need to use the importance of provisionalization to create the proper emergence profile and interproximal contour to guide the soft tissue during healing. And then we need to fabricate a definitive restoration that's going to go ahead and mimic the provisional that we created to help as well guide and support the soft tissue. The primary purpose of a dental implant is to replace the tooth, but of equal importance is preservation and support of the soft tissue. If preservation of hard and soft tissue structures is the primary goal, then we need to utilize techniques with that goal in mind. What are some of those techniques? Well, one of them that we know from literature is the immediate implant placement. We know that if we remove a tooth and are able to put back an implant in its place with an atraumatic extraction, we can preserve hard tissue and soft tissue. We have the importance of the implant system that we're going to use, the implant design, and the type of implant abutments. Again, we need to use implants that have now brought to today's world platform switching in their design and the use of custom abutments that are shaped like teeth, natural teeth, and not just round. Because the use of just round abutments, we have very little tissue support, as opposed to using ideal tooth-shaped abutments, we can get better tissue support. So in a case like this, on the left we see what true tooth form abutments would look like versus stock abutments, and how they allow us to contour and preserve tissue, as well as control where the cementation or screw access would be in abutment situation like this for stock versus custom CAD/CAM abutments. The third thing that we need to keep in preservation is the custom provisional restorations, because they become the blueprint for the final restoration. The customized provisional, along with sound surgical procedures and the use of proper implant fixtures, will help preserve hard and soft tissue. So what are some of the primary benefits of immediate provisionalization? Well, some of them are preservation of osseous and gingival tissue. They allow us to guide tissue during the healing phase. They allow us to provide optimal aesthetics during the healing and eliminating the need for removable or fixed prosthetics as provisionals. Additionally, it allows us to duplicate the emergence profile of the extracted tooth at the time of surgery. It begins immediately to support gingival abrasion form and maintain soft tissue contours. And practically, it allows us to reduce chair time and the number of appointments, as well as eliminate additional stage 2 surgeries. Immediate custom provisionalization technique also allows us to address the placement and the position of the restorative margin in the beginning. So by fabricating and creating a provisional where you know where the margin is going to be placed from the beginning allows you to create the proper contours in your provisional and be predictable as you move forward, creating where the restorative margin will be at the time of surgery. The key point and important issue to understand here is that the general dentist, the restorative dentist, is the one who's responsible for the final gingival levels and the contours as we move forward to the final restorations. Another key point that we need to keep in mind is that the timing between placement of the implant and the provisional. We've learned from the literature that we must perform that within the first 24 to 72 hours so we do not disrupt and avoid disruption of the immediate and initial integration, osseointegration of the implant fixture. There are two immediate provisional options that we can talk about and we can use. The first is laboratory fabricated prior to or time of surgery, and this can be done by computer-guided fabrication or traditional lab fabrication with stone models and lab components. The second is custom fabrication by the clinician chairside at the time of surgery, and here we can utilize what we call a direct fabrication or a combination direct-indirect fabrication with stone models. Now, prefabricated or laboratory fabricated provisionals have advantages and disadvantages. Some of them are that they are highly aesthetic provisionals. By using these, there's no provisional implant components that you need to learn and use chairside, which means that only a minimal skill is required for their placement. Some of the disadvantages, however, are that the provisional may not address issues and tissue requirements presented at the time of surgery. And sometimes computer-generated or prefabricated provisionals may not represent the exact clinical situation as it presents. The provisional may require significant customization. Those of you who do lab fabricated provisionals understand that sometimes they come back, they fit great, other times you have to do significant modification in order for them to fit properly. There's also the additional lab expense for fabrication of a provisional, and then the multiple appointments that may be needed in order to deliver these components. Now, custom fabricated provisionals, they also have advantages and disadvantages. Some of their advantages are they get to capture the situation as it presents surgically so that you can handle any situation that presents. It has the added flexibility by addressing tissue situations as it presents. It allows for immediate tissue guidance. There's no additional lab expenses during the provisional stage, and there's essentially fewer appointments needed. Some of the disadvantages, however, is that it requires the use and knowledge of implant provisional components. It will require additional skill for the fabrication and placement of the provisional, and there will be some expense of the provisional components. Let's talk a minute about tooth contour and how it influences gingival form and shape of the tissue. This was initially described by Frank Spear. What I want to describe to you is three different shapes and sizes that we call tapered, medium tapered, or broad tapered. Now, the interproximal contour of the provisional influences the soft tissue position between implants and teeth and implants to implants. If we take a look at the first example, we have the tapered. The tapered form has the least amount of influence on the interproximal papilla, and its tapered contour may lead to blunt papilla, but there are times that we might want to use this as we slowly guide growth in tissue contours as the healing stage continues. The second example is medium tapered. This is a very useful and the provisional form that we use most of the time. It's useful with normal to thick tissue when there's adequate tissue available and you want to initially go ahead and support the contours and papilla as they present. The third and final type is what we call the broad taper. Now, this is useful with thick tissue or trying to close black triangles because the wide contour can help push tissue into proximately and help to squeeze the papilla coronally and help to close the triangle. However, caution needs to be exercised here because if you excessively over-contour this tooth and make it too square, it will have the opposite effect. It will squeeze out the papilla and not allow for papilla growth to occur. So as we just sort of look at these three together in their form, let's take them as examples. So if we use a tapered, in this situation, it will support the tissue, but it allows for us to slowly use this form to help guide tissue over time, knowing that there may be space or interproximal inadequacies in the papilla. The medium taper usually brings us to a very good position and allows us time to just let the papilla go ahead and mature and grow into place. And then the use of the broad papilla is in a situation that we've showed before where we need a broader, more firm or flat contact to help to support the tissue and close interproximal space.
As Dr. Lemongello was saying, not only does the interproximal contour affect the shape of the papilla, but now the facial prominence of the provisional can also affect the soft tissue contour of the marginal tissue. We have here examples of a flat contour, a medium contour, and a convex contour. As you flatten the facial contour of the provisional, this is trying to influence the tissue to grow more coronally or incisally. As we increase that convexity, we're actually pushing on the tissue and trying to influence it to go more apically. So there are situations where after the implant is placed, we're trying to influence this soft tissue to either grow down more so that we're covering more of the tooth. In the center example where it's a medium contour, here we're happy with where the tissue is, so we're using more of a medium contoured anatomical provisional. And in situations where we have a little bit too much tissue and we want that tissue to actually recede, we're going to increase that convexity and try to influence that tissue so that it will go more apically. Here's an example of our custom healing abutment where we're capturing the subgingival contour, and as we're adding composite, in this case Luxaflow, to the contour, we're trying to bulk it out to influence that tissue to grow more apically. So in another diagram, you can see on the left-hand side, if we want the tissue to grow more coronally or incisally, we're going to flatten that contour. In the middle, if we're happy where that tissue is and we just want to support it, we're going to use more of a medium contour of the provisional. And on the right side, if we want to influence that tissue to grow more apically, we're going to add to the contour. We're going to make it more convex. We're going to push on that tissue and we're going to make it grow more apically or recede more apically. Here is our provisional, and you can see as we insert it, we're getting a blanching of the tissue. Now, if we want that tissue to stay where it is, we want that blanching to go away within the next 5 minutes. But if we're trying to influence that tissue to grow more apically, we're going to put pressure on that. We're going to screw that temporarily down or cement it in place. We're going to keep that pressure on and then evaluate the tissue in a week to 2 weeks. Here's a case where a patient had crowded lower anterior teeth, was not happy, and wanted to look into doing something like Invisalign. When taking x-rays, we noticed that the lower left lateral, tooth number 23, had external resorption. So we went ahead and we straightened the teeth with Invisalign, and then we referred this case to our periodontist who extracted the lower left lateral, and placed an implant. Now, again, in order to move this tissue more apically, we want to increase the facial convexity of our provisional. If we want the tissue to come more coronally, we're going to reduce that facial convexity. So in this case, we had a lot of tissue, and this is what we like to see when we get it back from our surgeon. So with our provisional in place, you can see that we're getting the tissue to blanch. We're trying to influence it to recede. Here's the provisional 2 weeks later, and then a week after that. So now we're happy with where our marginal tissue is. We'll go ahead, we made our zirconia abutment, and then our final restoration in place, and you can see that we got the tissue lined up very nicely.
Let's go ahead now and talk about the custom provisional techniques that we use. We have two categories that we're going to discuss. Those two categories are for traditional healing time and then after immediate placement. And the techniques that we use are what we call the direct fabrication or the indirect start. Now let's go ahead and talk about custom provisional techniques that we use. There are two categories that we're going to discuss. Those two categories are traditional healing time or immediate placement. Now the categories that we're going to use and discuss here are the direct fabrication or the direct indirect fabrication. So where do we begin? As always, we begin with the diagnostic phase. The position of the implant must be predetermined with information derived from the diagnostic phase. That information must include the proper clinical findings and examination, the radiographic findings to determine what needs to be treated, and study models in order to study the occlusion and the position of the teeth. A diagnostic wax-up can be created to aid in the fabrication of the surgical guide and for the provisional matrix. The surgical template is used at the time of surgery to guide the implant placement and position, while the provisional matrix is used to fabricate the provisional. So let's go ahead and take these one at a time. So let's discuss traditional healing time and the direct fabrication technique. Custom provisional technique, traditional healing time. Here's that case that we introduced early on. We have a situation where the person is going to lose their lateral incisors, and this is how they present after healing has taken place over the course of time. What we end up with is two healing screws. We can see the one on the left is not in such a bad position. The one on the right is a little short. So if we have a situation where this is the way it presents, and we look at the screws from on top as well, we see that these are round screws that offer very little subgingival contour and shaping to our tissue when we begin. So how do we start? We go ahead and take our provisional abutments and we put them in place. And if you notice how inadequate the support of the tissue is, if we were to just go ahead and try to take an impression here and create the restorations, there'd be no guide or no blueprint to how to move forward. So what we're going to do is we're going to shape these two provisional abutments in some form of tooth form. We're going to do a little laser of the tissue to help contour the subgingival contours, and we're going to start to create our provisional. We're going to go ahead and use a little Luxitemp here. We're going to squirt around the teeth. We're going to fill up our matrix that we created for the provisional, and we're going to bring it to place. What we end up is two shells, typical of what you'd see for crown and bridge, with a little bit of that fin that has captured a little bit of the subgingival contours. So we can go ahead and get to work. We go ahead and take our provisional, we start to trim off the flash, we start to add in any negative space where the contours are not supported enough with flow composite until we create a provisional that has the contours of a lateral incisor. We can go ahead and then bring those to place and see how we like the way they fit. And as discussed before, if we were concerned that the tissue support was inadequate, we could add to the contours, or if we felt that it blanched too much, we could reduce it until we were happy with the situation as it presents. We can then go ahead and use those provisionals. We can have our final abutments created in the same shapes and contours of the provisional as the blueprint, and we end up with a final result to mimic what we've created before. And here we have a an image of the final crowns in place. The reason we've been successful all along, again, is by adhering to the 5mm rule, where we've been able to preserve the bone between the contact point and the crest of bone. So here's another case, custom provisional technique after traditional healing time. This was that case where we had the large vertical defect that I showed as type 2 in the beginning. As it presents to us after surgery, here was the defect. The implant is placed and the healing's occurred. But as before, what we have is a under-contoured area with a round screw that we need to shape and create proper subgingival contours and emergence profile. So we remove the screw, we get a provisional abutment, make sure that it fits the size. We go ahead and begin to add flow composite to the base and subgingival area of the provisional, creating the contours that we need. We then go ahead and bring it back to the mouth, and as we can see, we get a little blanching, and when we push it to place, it really has about the right thickness that we need to have. We can again go ahead and then prepare it as if it were a natural tooth, shaping the tissues and the contours as we go. So here's the provisional abutment with its contours, and then back in place in the mouth from above and in front so we can see the shape. Go ahead and place the provisional, and you can allow this to then go ahead and heal and mature for the next few weeks prior to take your final impression. Fabricated zirconia abutment and crown to mimic the size and shape that we've created, and then the final result in place. Exceptional results do not happen by accident. It is the attention to detail. It's the proper treatment planning from the beginning, the surgical techniques, the healing phase, the provisional abutments, and then the final restorations. Let's now go ahead and change to speaking about the immediate placement at time of surgery, and let's go ahead and use the direct fabrication technique. So here we are. This is a situation where the patient presents to you with a fractured lateral incisor. We're able to let her get straight to the surgeon. He's able to remove the tooth atraumatically, and we're able to have that patient come back to us and initially place our provisional abutment. So this is how the case presents after surgery. We go ahead and fit our abutment, take it out, we start to work on the subgingival contours like we've done before. We get it polished and shaped, we bring it back to the mouth and push it to place, and we assess whether or not we like the way it supports our soft tissue at this point. If we're happy, we can go ahead and then fill in the access screw. Now, because we don't have a wax up and matrix for this, we have the flexibility of creating the tooth chair side at the time of surgery. So the way we're going to do this, we're going to get some flow composite. We're going to go ahead and just continue to flow composite, start to build up the tooth, create the contours in the flow composite. Then we're going to go ahead and take our burrs out. We're going to start to shape the tooth, shaping the contours, shaping interproximal, until before long we have what begins to look like the normal shape and size of a lateral incisor. We then go ahead and remove it, and when we do so, we find that we have captured the subgingival contours and we've captured the coronal portions in the provisional, but there's the gap that's occurred between the two. We now need to go ahead and with flow composite marry the two together, filling in the seam and creating the final coronal and subgingival contours of the provisional. Bring it back to the mouth, bring it to place, assess our aesthetics and our tissue position, decide if we need any other modification. If not, we go ahead and take it out, we glaze it, bring it back to place, screw it into position, adjust our occlusion so nothing touches it in both anterior and lateral excursions, and the patient can go on and heal with this provisional in place after providing an aesthetic and immediate situation to her fractured tooth in the case as it finishes.
Next, we're going to talk about the customized provisional, the direct-indirect technique. In the direct-indirect technique, the patient returns to you after traditional healing time, whether you have a flipper on this tooth or another type of provisional. You have your round healing abutment, healing cap in place. We'll unscrew that healing cap We'll see where the head of the implant is and place one of our impression abutments or impression copings. We'll go ahead and take our impression, and this we're using a closed tray system where we'll reset the impression abutment inside the impression. Now we'll go ahead and use a product from Ivoclar called Gingertech. We'll inject that all around the implant to simulate the soft tissue. And we'll go ahead and pour a master model. Once that is set, we'll unscrew our impression abutment. And there we're looking down at the head of our implant. Now with the burr kit that we talked about before, we're going to use the burr on the right, the 6856, which is a large diamond. And we're going to start to recontour that subgingival area on our model. Here we're recontouring to the shape that a central incisor would have subgingival. Now, you could either do this on the same appointment or have the patient back for the second appointment. We'll come in and with a laser, we'll go ahead and start to widen that opening that the round healing cap had given us. I try to stay away from the facial contour, so we're winding it from the lingual and a little bit interproximally. We'll take our plastic provisional abutment, put it into place. And now we'll start to trim this in the mouth. We'll take away from the circumference if it's sticking out too far facially and shorten it incisally. And now we're going ahead and prepping that abutment. Once we're finished prepping the abutment, now we'll take it to our model. We'll put it into place, screw it down, and now we'll start to utilize flowable composite that we're flowing all around the subgingival area that we've shaped with our burr. Once that's in place, we'll go ahead and cure it, unscrew it, and then trim it up outside. Any areas of voids you can go ahead and fill in with the flowable composite, and we'll smooth that down. We take that back to the mouth and screw it down and see how much support we're getting for the tissue. Again, if we wanted this tissue to recede, we're going to bulk out the contour and put more pressure on it so it blanches. If we like where the contour is of the marginal tissue, we want this blanching to go away within 5 minutes. Now we'll go ahead and seal the access opening of our provisional abutment. We'll seal that up with a bite registration material. Lubricate the provisional and go ahead with our index that we have from our wax up to make a provisional crown. Once we take that provisional crown out, we'll unscrew our provisional abutment. We'll bond the two of them together like that. And then with an access opening from the lingual, we'll insert it back in, screw it into place, make sure that we have the right amount of tissue support that we're looking for, and then our final restoration in place supporting the tissue.
Let's go ahead and talk for a minute about what we call a subcategory of the custom provisional technique, which is the custom healing cap or healing abutment, which is illustrated here. We'd shown the custom healing cap or healing abutment in the initial case, the trauma case that we presented earlier. Here, what we do is, instead of using the traditional round screw as a healing cap or abutment, we go ahead and create a custom fabricated healing abutment or healing cap that is placed at the time of surgery. What this does is it allows the immediate guidance and support of the soft tissue during healing. So as we used in this case, right from the start, the tissues have begun to be guided and is allowed to heal around the custom healing cap, so that when we get to the point of we're ready to create the custom abutment for the provisional, most of our tissue healing and tissue contouring has already been completed, even in as short a time as 3 months post-surgery. From there, we can go ahead and create our custom abutments with minimal additional shaping and contouring. The custom healing cap or healing abutment allows us to take control of the final outcome from the beginning.
Here's a case that we like to use as an example of utilizing a custom healing cap, transferring that into a custom abutment. This is Karen. Karen presented to our office with implants that were already placed in the central incisor area. She had taken a fall, been to see an oral surgeon, and without any planning, they went ahead and placed 2 implants in the areas of the 2 central incisors. She was wearing at the time a Essex temporary, and the oral surgeon told her now she was ready to go see her dentist to place 2 final restorations. As you can see, the tissue is not exactly in the area that we would like it to be. We were missing a lot of facial tissue over the upper right central incisor, and this was a place that, where do you begin? So what I did in this case was I went ahead and I made custom anatomical healing caps. I took a provisional abutment, I cut it down, we added Luxaflow all around the tooth to shape it to the contours of a central incisor, and in the mouth we went ahead and utilized our laser to shape the contour that we felt the central incisor would look like. But as you can see, we're deficient on the facial thickness of the tissue over the upper right central. So I screwed these customized healing caps into place, and I allowed this to heal for 2 weeks. When the patient came back 2 weeks later, we took a little plastic cup, filled it up with some quick-set plaster, inserted some analogs into place, and screwed this customized healing cap into place. Then we inject some impression material around it. We allow that to set, and then I'll use my diamond burr and clean up all around that subgingival contour. We'll take a second set of provisional plastic abutments, screw that into place, and then start flowing flowable composite all around the provisional abutment to capture the subgingival area. We'll screw those provisional abutments into place. We had a wax up done for the 2 central incisors and a clear plastic matrix so that I can make sure and see that I had enough clearance on the facial. We inject some Luxatemp into the clear plastic matrix, put this over the abutments that are lubricated. We allow this to set for only 1 minute and take it out. Once we've taken it out, we unscrew our provisional abutments. We put it inside our provisional crowns and bond the 2 of them together, and then with composite polishing instruments, in this case I like to use the Enhance points and cups that are made by Caulk. We'll smooth that subgingival area down, and then we'll screw this into place. And as you can see, this is our first set of temporaries, but our marginal tissue is more apical over tooth number 8, which is the upper right central, and you can see that we're lacking thickness in this area. I referred this case to my periodontist, who went ahead and did a connective tissue graft over the 2 central incisors to bring the marginal tissue down to the proper area and to add thickness to this. So this is healing after about 8 weeks. Now the patient at this point has a very, very high smile line. She was very happy with the way these two central incisors looked, and we started to have a discussion about restoring the rest of her smile with porcelain veneers. At this point, I felt that doing crown lengthening would be beneficial to her full smile, so we would mark with some marking pencil to show the periodontist where we would like him to raise the tissue to. We communicate this with photographs and measurements. And then 2 months later, after the crown lengthening is done, and you can see the tissue graft is starting to heal even more, and the tissue is starting to flatten out, we get this result. We unscrew our provisional crowns on the two central incisors, and we can see how nice the tissue is healing and the marginal tissue is taking shape with a really nice papilla interproximally. Looking from the occlusal view straight down, you can see how we've gained thickness with the connective tissue grafts. We'll go ahead and use our impression abutments. We'll customize those in the mouth to capture the subgingival contours that we painstakingly took the time to create with our provisional abutments. We'll reseat the impression coping inside the impression. And now what we'll do is we'll take a stump shade of our porcelain veneer preparations on the right side and the left side. And then these are our final provisionals in place. So we'll take photographs and impressions to send to the laboratory to communicate the contours and the length of our teeth. Now, because we've taken so much time to create the subgingival contours, our laboratory is going to pour up this model and is going to use an implant split cast epoxy dye over the implants. We don't want to push on this tissue at all. That's why he hasn't used a flexible material that we used before, like Ivoclar's material, but he wants to capture the exact contours that I've created and transferred to him. Now, we'll go ahead and we'll make custom porcelain to titanium abutments, and this porcelain is the shade of the stump shade that we use for our veneer preparations. Here's our final restoration. We're using two all porcelain bondable crowns on the two central incisors that are going to bond to that porcelain to titanium abutment. And now veneers on the upper right side, the upper left side, and all the lower teeth. Here's the final restorations. Again, porcelain veneers, all porcelain crown, and our porcelain to titanium abutments. Here's the abutments in place, and you can see how we've matched the color to our adjacent teeth, to the adjacent dentin. So once the restorations go into place, you can see the matchup that we've gotten between the central incisors, which is over this custom porcelain to titanium abutment, and the porcelain veneer, which is bonded to our natural dentin. There's the patient's smile from the front view and the two lateral views. And then there's our happy patient from the front and the side. And just to remind you where we started, here's the patient coming in with an Essex retainer, a very high smile line, showing a lot of gum, very tiny teeth, and actually dark buccal corridors where the bicuspids were more lingually oriented. We've naturalized her smile, we built out the buccal corridors, and we've given her shapes of teeth that fit her face. Again, where we started from, no planning done. This wasn't a situation where we were able to work with our surgeon beforehand and actually plan these two implants. And sometimes you get this in private practice. This is, reality. And how are you going to make this work? And again, with our final restorations in place, you can see the nice connective tissue grafts that were done over these central incisor implants. And over the next year, this is going to look even better as this tissue smooths out and the color and the contour starts to get even more even. Okay, the last thing we'd like to talk about is the custom impression coping, whether we do it direct or indirect. So let's look at the direct technique first. Again, we have our provisional abutment. We've shaped the tissue to the position that we like it to be. We'll unscrew that provisional abutment. We'll screw in our impression abutment or our impression coping. And then in the mouth, we'll go ahead and flow the Luxaflow or any type of flowable composite you like to use. We'll flow that all subgingivally and then go ahead and cure that. Once that is cured, we'll unscrew that. And here's our impression abutment unscrewed. You can go ahead and fill in any voids with the flowable composite and polish and smooth that shape. Once that is done, we'll go ahead and screw that back into place. Go ahead and take our closed tray impression and reseat our impression abutment into the new impression that we've just taken. And you can see here how all the Luxaflow has captured beautifully the subgingival contours that we've created with our provisional abutment. And now our master model. Now the second way of doing this is the indirect technique. Once you've again created the contours that you want with your provisional abutment and provisional crown, we'll unscrew that. We'll take a plastic cup, fill it up with some quick-set plaster, insert our analog into place. Once that is set, we'll screw our abutment and provisional crown in place. Then we'll take any type of impression material that you like to use in your office. We'll inject that all around the subgingival contour of the provisional. We'll allow that to set. Once that's set, we unscrew our provisional abutment and crown. And you can see how we've captured that subgingival contour in our impression material beautifully. Now we'll screw in our impression abutment, take our flowable composite, flow it subgingivally, cure that, unscrew the impression abutment, and just like we did in the direct technique, you can fill in any voids and then go ahead and smooth that down. And now you can compare your subgingival contour on your impression abutment and see how you've captured the contour beautifully that you've created with your provisional abutment and your provisional crown. That gets screwed into place, and then we go ahead and take our impression the same way that we've done with our direct technique. And here's the clinical case on the right and our master model on the left. So with that, we'd like to end today's webinar, but first I'd like to give a thank you, a very heartfelt thank you to some of the gentlemen who have been mentors to us and have been giants in the field of implant dentistry. I'd like to give real kudos to Maurice, Henry, and Eddie Salama for what they've done with Dental XP and the continuing education program that they put together. I think it's a wonderful continuing education online program, and it's been very successful. And they have these global symposiums that we're having our third one now in February. And I recommend that anybody who hasn't been to any of the symposiums, please come. It's an unbelievable educational experience. The second person I'd like to thank is David Garber. David is a true gentleman and one of the giants in the field of aesthetic and implant dentistry. David was one of my first mentors. I saw David in Florida 35 years ago, and he got me started along the aesthetic trail. And it's always a pleasure to be in his presence and being a colleague and a teacher with David. And the third person I'd like to thank is Dennis Tarnow, who again also has been a giant in our field of implant dentistry. Dennis has been unbelievable in teaching us all the new technologies and the new research that's been out. And I also would like to, send a heartfelt thank you to Dennis. With that, I'd like to thank you for your attention. I wish you the best of luck, and Dr. Lemongello and I, hope to see you at the Dental XP Symposium in February. And all we could say at this point is enjoy the journey. It's a great profession, it's a great field, and exciting things are on the horizon. Thank you.